Hi, my name is Dr Tasha and I'm a breast surgeon. Now, if you have been recommended to have a mastectomy as part of your cancer treatment, you don't have to have a reconstruction if you do not want one. However, if you do want a reconstruction, then there are options. You can either have an implant-based reconstruction or an autologous-based reconstruction using your own body tissue. One of these includes the DIEP or DIEP reconstruction, and that's the reconstruction that uses your tummy, the fat and the skin on your tummy to make a new reconstructed breast. In this video, I'm going to be asking 5 important questions to a surgeon who is an expert in DIEP or DIEP reconstruction. So if you are considering to have this kind of reconstruction, then this is the video for you. Hi everybody, thank you so much for coming to join us today. So we are going to ask 5 questions to the expert that we have today, who is Dr. Minas Chrysopoulo, or Dr. C for short, because apparently his surname is too long for people to remember. So Dr. C, thank you so much for joining me today, all the way from Texas. Let's start with the first question, which is question number 5. What is a DIEP reconstruction?
DIEP flap uses the lower abdominal tissue, so the tissue that women usually want to remove when they have a cosmetic tummy tuck or part of the mummy makeover. That lower belly tissue is used to reconstruct one or both their breasts after mastectomy for either breast cancer or risk reduction if they have a gene mutation.
Great. So it's a way that we can use we use a bit of the tummy to create a new breast for somebody who's been recommended to have a mastectomy, either at the same time as your breast cancer operation or as a delayed operation. So that's anything 6 months or any time in the future.
Anytime, yeah,
anytime
absolutely.
In the future.
There's no time limit. You can have a DIEP flap reconstruction at any time after a mastectomy, if that's what you want to do.
Great, perfect. So question number 4 is, who would this kind of reconstruction be suitable for?
Anyone who's generally healthy and has lower belly tissue that they want to get rid of. Most people are going to be candidates. There's sometimes other medical problems. Someone who's had many abdominal surgeries. I don't mean the occasional C-section or something like that. I mean major abdominal surgery.
Right.
Won't be a great candidate. And if you don't have enough lower belly tissue, you're not a great candidate. But most women have enough tissue for at least a B-cup breast. Right.
So you will also do some scans beforehand to check, whether the blood supply to that part of the tummy is viable. And if that is the case, then there is no reason why somebody should not be able to have this kind of reconstruction. Which kind of leads us to question number 3. Who would this kind of reconstruction not be suitable for? So, which kind of patients would you consider, unfortunately, I don't think this kind of reconstruction would be suitable for you.
If you've already had a tummy tuck, that tissue's already been removed, so you're not a candidate. If you have very advanced cancer that needs to be taken care of and controlled, you're not a candidate for immediate reconstruction. Sometimes, depending on the stage of the disease, and if you have other medical problems that aren't well controlled, if you have diabetes and your blood sugars aren't a high, if you have high blood pressure and that's not well controlled, so really you have to, if you've got other medical issues, which a lot of people have, you have to get tuned up before you're the best candidate you can be.
Right. So medical issues, so, other kind of comorbidities such as blood pressure, diabetes, things like skin conditions, lupus, for example, those are kind of things that might hinder somebody from getting it. And I guess also lifestyle things.
For sure. Yeah, smoking, that's a no-no. That's a really
Right.
bad idea before any major surgery. So most of us microsurgeons won't offer this in active smokers because there's a high risk of things not going well, high risk of complications. So it's not in your best interests. Don't, if you're a patient, for heaven's sake, don't lie about your smoking history. Be honest
Yeah.
because you're only hurting yourself. So
Yeah.
smokers can still have reconstruction once they've been off their smokes for a while. So it's not never, it's just not now.
Okay, that's really good advice. Yes, and again, please don't mask the truth. If you do smoke, please tell the surgeon you are smoking, because the consequences of that is just, it's not worth taking. Okay, so that leads us to number two. Following from what we've just talked earlier, what are the possible complications pertaining to this particular operation, namely deep reconstruction?
So it's a tissue transplant procedure. So that means that the tissue is disconnected from the belly, disconnected from the body, and transplanted and then reconnected using microsurgery. So the new breast has blood flowing in and out. That has a very, very high success rate, but it's not 100%. So it's less than 1% risk of failure, but about 1 in 100 people, the tissue reconstruction won't work because the blood flow will be interrupted, either going in or coming out of the tissue, and then that requires more surgery.
Right.
General complications or risks after any major surgery: bleeding, infection, wound healing problems. Chronic pain is also a risk after any surgery, and that can be whether you have reconstruction or not. That's not just specific to deep flaps, but and specifically to the deep flap, lower abdominal problems like a bulge or a hernia. Thankfully, those risks are very low because we're saving all the muscle.
Right.
Unlike the kind of the iterations of this surgery that came before it, like the tram flap, for example. The tram flap removes the belly muscles, the six-pack muscles, the
Right.
abdominal muscles, as part of the reconstruction. And then the patient requires a big piece of mesh to kind of span the gap. Well, the deep flap preserves all the belly muscles and just removes the skin and the fat. So the outside scar is the same, which is hip to hip, like a tummy tuck scar, as low as possible, preferably. But the internal stuff is completely different. So saving your muscles is a big deal. So, and that's why that's what leads to such a low risk of hernia or a pooch. So
Right.
less than 1% risk for a hernia, 3% risk for a pooch.
Right. As you said, less than 1% fail, between 1 to 3%, generally, that's the failure rate that's quoted. So the majority actually work. So, which is fantastic news. But despite that, I guess people still need to know what the potential risk and complications to any procedure, really. So that leads us to the last question, which is number one. And I'm going to leave this to you, really. What are the other things that people may not have thought about when they have this kind of reconstruction?
Feeling. So mastectomies typically leave patients numb, at least partially numb. Some women are totally numb after a mastectomy. So some breast surgeons now are being more careful during the mastectomy to try and preserve the nerves that supply the feeling to the breast. So I would say to patients to talk to their breast surgeons about nerve preserving mastectomies. That's a pretty new topic. So be prepared for, if your surgeon doesn't automatically kind of agree, be prepared for some conversation about it, but push for it because everyone can do it.
Yeah.
And if the nerves cannot be preserved, or if you're having reconstruction as a delayed reconstruction, so sometime after the mastectomy, then you also have the potential to reconstruct the nerves that supply feeling. And the DIEP flap, of all the flap options, all the tissue options from various parts of the body to reconstruct the breast, the DIEP flap actually has the closest sensation to the breast in terms of nerve endings. So we routinely in our practice take a nerve that supplies feeling to the belly tissue. We take that with the tissue that we're using to reconstruct the breast, and we'll reconstruct the feeling, reconstruct the nerves in the breast to help provide more feeling long term. And it's a big deal. It's even if it's not erogenous, it's very important to be able to feel the reconstructed breast so that you have protective sensation. I mean, we see women from other institutions all the time that didn't get nerve reconstruction, and they'll burn their skin because they couldn't feel anything, or they'll get a cut or something, they didn't feel anything. Sometimes they'll have some chest achiness or something after a mastectomy, and then after the reconstruction, someone will say, "Oh, just put a warm compress on it or something," and they'll get a cloth, wet it, put it in the microwave, put it on their chest, and they don't test it on their forearm or somewhere that's sensitive, and they don't realize it's really, really hot, and they end up burning their skin. So if you have sensation in the reconstructed breast, it's protective. It can be the difference between feeling a hug or not. And then of course you've got all the other kind of personal stuff with your partner. The ability to feel a touch is a big deal.
Yeah, great.
So
that's really, really important.
I would say that's kind of probably number one. We've been doing it in our practice for many, many years, but it's finally starting to kind of become more discussed. Again, not everyone offers that kind of stuff, but it's something that people need to be aware of.
Yeah, no, you're right. I don't think many people, I mean, certainly in the UK, we don't, we're probably lagging slightly behind the US in that regard. So that's definitely something that we need to look into a bit more. But so, yeah, that's amazing answers to these 5 short questions. This is a snippet of a far lengthier podcast episode, which you can check, and I will leave it in the link below. So if you want to, delve into a deeper conversation about DIEP reconstruction with Dr. C, who is plastic surgeon, DIEP expert, that's his, he's an expert in this field, then do check it out. I would highly recommend it. But Dr. C, thank you so much for your time. Really appreciate it, and catch up with you soon. Take care.
Sounds great. Thanks.